Okay. Okay, Doctor. We'll start the webinar now. So, good evening, everyone. So, first, I want to welcome all of you to join today's webinar. My name is Lin, and I'm from SYM Medical. I'm honored to be the host of today's webinar. So, at first, I'm going to give you a brief introduction about Dr. Anurag. Dr. Anurag is a pain spine physician professor in India. He is also the founder president of Endoscopic Spine and Interventional Pain Society of India. And next, we'll give a brief about today's meeting's agenda. So this webinar will last for 1 hour. So for the first session, we will have Dr. Anurag give us a 40 minutes presentation about detailed PBC procedure for trigeminal neuralgia. For the second session, we will leave 20 minutes Q&A time. So Dr. Anurag will answer any questions related to PBC procedure. So now let's welcome Dr. Anurag to start his presentation. Thank you. Dr. Anurag, please unmute. Yes. Thank you.
Sorry. Good evening to everybody, and I welcome you to all. And now, without much ado, I'm directly going to share. Can you see the Lynn? Can you see?
Yes, we can see the slides. Yep.
Okay. So today's topic is percutaneous balloon compression as a treatment option for trigeminal neuralgia. I'm Dr. Anurag Agarwal from India, Lucknow. Lynn has already given my introduction very well to all of you. I welcome you all. This is my place where we work at Dr. Agarwal Institute of Medical. This is just to put the things in perspective. May I ask everybody to please unmute? Yes, thank you. This is just to classify the trigeminal neuralgia into two. Which is one is the primary, essential, or idiopathic, which is fortunately the 90-95% cases, where no known cause of trigeminal neuralgia is present, but vascular compression is the most common anatomical finding. And secondary, where this is due to some reason of intracranial pathologies like multiple sclerosis or tumor, etc. This classification is important to understand because whatever we do with the percutaneous balloon compression, it has been found to be more effective with the type 1 trigeminal neuralgia. Again, everybody knows the shock about it. And this third point in this slide is pain-free interval between two shocks, which is a defining feature of type 1 and type 2 neuralgia. So, as I said earlier, type 1 neuralgia responds better to all the percutaneous technique, especially the balloon compression. Treatment, again, everybody knows it. We are going to talk about the minimal invasive percutaneous balloon compression. And we have done 2 cases where microvascular decompression has been failed, but the patient responded very well to the percutaneous balloon compression. So all interventions of the percutaneous variety, this slide just to show that here we are targeting the gastric ganglion, not the peripheral nerves. This is V1, V2, and V3. Here you can see the balloon compression. And in all the percutaneous interventions, we target the balloon compression. As you can see that in the percutaneous balloon compression, we put our balloon in between in the middle of the gastric ganglion, and then we compress it against the petrous temporal bone. So balloon compression was discovered, you can say, by Dr. Mullen and Dr. Luster in last century's 80s. And since then, it has been used extensively, and it has been found very, very effective, perhaps more than other percutaneous techniques. So this is just for the anatomy of little bit. The route which we all use for all the percutaneous balloon percutaneous methods is the transoval route. This approach is not new. It was given more than 100 years back by Dr. Hartel in 1912, and who used alcohol to treat this dreadful condition. So to reach the gastric ganglion, we which is situated in the Meckel's cave, we still use this transoval route, which is most commonly and most approachable. So this is again to rectify things which I was saying earlier, that you use the transoval route, which is the Meckel's cave, where the gastric ganglion is situated, and then you compress this gastric ganglion with your balloon, inflated balloon. Here you can see that V1 is going out, V2 is going out, but we can target all the three nerves in the gastric ganglion with the balloon. Again, this slide is important to again show that the anatomy. Here you can see that these are the three peripheral branches, and this is the gastric ganglion, but these are the trigeminal, motor, and sensory. And this, these roots are coming through the porous trigeminiacus, this place where you can see the cursor. They are coming through the porous trigeminiacus, and this has got very much significance of the ideal pear-shaped balloon. You will come to see it later also. That it is very important to compress these nerves if you want to have the full effect of balloon compression in the trigeminal nerves. So to describe the procedure, patient is in the supine position under general anesthesia most of the time. C-arm fluoroscope is the must thing to reach in the Meckel's cave through transforamen oval route precisely and without much morbidity to the patient. The view, which is very much important for the transforamen oval route, that is submental vertex view. See how we make it. And entry point is usually 1 inch or 3 centimeter later to the angle of. This is the balloon compression assembly. It is quite simple. Here you can see this is a 4 French balloon. This is a manometer which has been provided by the company and which is the new addition to our armamentarium. And now we can measure the actual pressure which we are generating in the Meckel's cave while doing the compression. And this is the 14 French 14 gauge cannula and assembly, and this is the dilator which we use through this cannula to make a smooth path for our this 4 French balloon. And these are the syringes to inflate the balloon. And here you can see a picture of a patient in the AP view in the fluoroscope with the inflated balloon in the Meckel's cave. Sorry. This is you can see an actual patient who is lying on the OT table, and C-arm is in the submental vertex position to see the foramen oval clearly. Now, this is a small video of around 8 minutes to show you the actual surgery of percutaneous balloon for a trigeminal neuralgia patient. Oh, okay. I'm sorry that I've just come to know that you are not getting my sound, which is there in the video. So I'll explain it. So now we have located the foramen oval after making the mm, after making the just a moment, after making the cemento vertex view, and we are trying to target the foramen oval in a gun barrel view under the SYM flow or coaxial view. So we are trying tenderly to reach the foramen oval first. Here it is important to reach the foramen oval only and not too much advance into the macroscope with your needle. So you just stay at the gate of macroscope, that is foramen oval. We have already reached the foramen oval, and now we are checking it in first in the AP view. And yes, we have almost see that. Now we will check the depth in the lateral view of the SYM flow. Now in the lateral view, you can see that our cannula has reached the foramen oval. It just crossed the foramen oval. We are trying to make a better picture. Trying to remove the parallax. Here you can see this is the sella, the metal scale. This is our cannula tip. I have just slightly withdrawn it into the metal scale only. From here onwards, we will go with the now the parallax error is completely removed. Here you see. Now the slit has been out. And we are using the dilator to make a path for the placement of our tool. Now you can see that here this guide wire, or you can say the dilator, has passed the active state through the Gaussian cannula. The same place we will insert our four-front specialized balloon catheter. This balloon catheter has also got marks to see the depth. Whether the first mark signifies that the tip reaches to the tip of canal. Second marks goes almost 1 inch ahead of. That is the place we usually intend to teach while doing the percutaneous. And here also, you see, sorry for the unprofessional quality of balloon. But here is a marker, a steel marker, which is below. It shows you the exact depth of balloon while doing. Now we have started inflating the balloon, and you can see the manometer. I again say this is a big welcome addition to this intervention. Because before that, we were unable to measure the pressure which we are doing. And here you can see the balloon has started to take a shape. and it is taking a shape of tear. Yes, you can see the notch of peak of tear here. You can see this part. This is rodent part. So this is the ideal shape of a balloon during the percutaneous balloon compression. Here, it is important to understand that the notch or this peak of tear is shows that a part of our balloon in the porous trigeminus, which the roots of the trigeminal nerve is coming into the gastric gland. If you are not getting this percutaneous balloon tear shape, uh, many authors, many researchers, and our experts say that this provides relief that is not that long lasting. It is with the tear shape. See that shape, compress it 20 seconds, and with the help of manometer, can measure the pressure, which we have found to be very high, it's almost around 2000 mercury or 200 kPa, with only 0.6, 0.7 ml of dye. So this pressure perhaps is causing the pain relief. This is the mechanism of pain relief. Here in this picture, you can see a balloon with the marker. Now the procedure is over. In half minutes. Inflate the balloon. Completely. Once the balloon has been deflated, the tip the complete together, as well as the cannula. So this PVC surgery is over, but it is very important to compress the for at 5 minutes to decrease the chances of any stresses or leakage. Most of the time, in our experience, our patients from anesthesia pain-free without any neurology. They have a mild with, so the advantage of balloon compression that it is useful for all patients. Initially, it was considered a reasonable option only in the elderly who are unfit for the major surgery. But we have found it is very useful for the young patient also. They also equally respond very well. It is very good, especially for the B1, that is ophthalmic division neuralgia, because with balloon compression, the corneal sensation remains intact in most of the patients. But there is a slight sensory loss is there, but it is equivalent to all other techniques, whatever we see and do. It is easy. Patient cooperation is not required because it can be done in general anesthesia. Sometimes when we do radio frequency, patients are unable to tolerate it because their patient cooperation is very much required. There are some disadvantages, like in most of the patients there is mesenteric weakness, but the good part is that it gets better with time. Within 4 to 6 weeks, most of the weakness of mesenteric it goes away. But then there are chances because there is invasion of foramen ovale and necrosis. So infection is a reality which may happen, but fortunately we haven't encountered a case till now. There are some cases of slight dysesthesia, some ear pain. Patient complain in the immediate post-operative period, which gets better with mild drugs like the NSAIDs. The single most important thing during PVC is severe bradycardia and transient assistance. The incidence which we have found is around 30 to 40% in cases, So your anesthesiologist colleague should be ready with the atropine, which can be used for if it happens. There are some complications which may happen with the percutaneous balloon compression. This is majorly related to the positioning of cannula, because remember, it is a 14-gauge cannula, which is quite big. If you are superior to infraorbital fissure, retroorbital hematoma can happen. If you are posterior to foramen ovale, injury to carotid artery may happen. Here you can see in a CM picture, this is sella, this is clivus, and this is the carotid artery, which is going quite near to the place where you are going to put. So we need to take care. The complications are facial numbness, as I said. Sometimes there is dysesthesia, which require neuromodulatory drugs like the gabapentin or pregabalin for 3 days. Anesthesia dolorosa, again, the incidence is very, very, very low in comparison to other procedures like the radiosurgery, radio frequency, or even with after the MVD. Decreased corneal reflex is very rare with balloon. But hematoma, because of the larger cannula, especially if you do not compress the puncture site for a significant duration, it may happen. Slight motor weakness of mesenteric muscle may happen, and other things. One more thing which I have seen in around 0.5 to 1% cases is herpes labialis. The eruption happens after 3 to 1 week after the percutaneous balloon compression, but it is quite innocuous. They respond very well to the antiviral drugs, and patient. So here, in this slide, you can see that the complication of balloon. This is from the 2004 study. Is much lesser than the radio frequency or glycerol rhizolysis, and especially anesthesia dolorosa, which is very, very annoying and distressful complication. It is not there with balloon. So it is very good for V1 neuralgia, keratitis, that is also nil. Corneal numbness is also. So eye is safe and anesthesia dolorosa. This is comparative chart of many studies, famous studies of balloon compression that have been published. They also have found that initial pain relief is up to 100%. And fortunately, by God's grace, our experience has also been so far the same. All our patients, they wake up from anesthesia completely pain-free of their neuralgic pain. And they, almost all of them, are free of tegretol or carbamazepine in the post-operative. So the recurrence rate is still here. Different studies say different things. Corneal anesthesia dolorosa is 0. Only one study has found very slight incidence, 0.6%. Corneal anesthesia is again 0 almost in all the studies. But motor weakness is there. To some studies 30%. Our experience is around 15 to 20%. But that is usually mild. Only in 5 to 10% cases, this is significant to affect the patient. But it gets better. So to conclude, percutaneous balloon compression, in our opinion, is an amazing treatment option for trigeminal neuralgia, especially in the V1 ophthalmic division and multi-division. So this is my channel, Pain-Free India Dr Anurag Agarwal, YouTube channel and Facebook page. I thank you all for the patient and kind listening. I hope I made my presentation for you, and I urge all of you that we must use and extend the benefit of balloon compression, which is a really minimally invasive and wonderful treatment option for the trigeminal. Thank you.
Okay, thank you, Dr. Anurag, for your excellent presentation. Now we come to the Q&A sessions. Can you hear me? Yeah? Yeah. And now we come to the Q&A sessions. If any of the doctors have any questions, please raise your hand in the little button down there. Yeah, I can see there's Doctor. Yeah, Doctor. Hi. Please Welcome, Dr. Ahmed. Yeah. Okay. And yeah, we can hear you, doctor.
Okay, thank you very much for the excellent presentation from Dr. Anurag. I have one question. How about if the trajectory of foramen ovale is covered by mandibula? Do you have any suggestion about that? Sometimes the ovale foramen, the position is vertically, and covered by the mandible. What do you think? Thank you.
Thank you, Dr. Ahmed. Dr. Anurag, did you hear what the doctor just asked the question?
Hello.
Hello, doctor.
Hello.
Hi, we can hear you, doctor.
Hello. No. No, I can't hear.
We can hear you, doctor. Did you get a doctor? There's a Dr. Ahmed. He just raised a question about how to reach the perfect pear shape. And now we're gonna welcome another Dr. Muhammad first to ask a question. Sorry.
Yes, I have a question. Is there any experience of this balloon decompression therapy in comparison to radio frequency ablation of the ganglion? And what sort of treatment has better results?
Hello.
Yeah, we can hear you now.
Can you hear?
Yes, yes.
Oh, finally. Thank you, Dr. Saleh, for the question. Yes, we have just completed our study comparing the radio frequency with the balloon compression. And our result shows that balloon compression is certainly better in terms of pain relief and in terms of medication use after the procedure. We are getting good results with the balloon radio frequency also. But most of the patients are requiring some amount of carbamazepine later on also.
Yes. In which group?
Pardon?
In which group? In balloon decompression or radio frequency group?
Radio frequency. Balloon compression people, most of them are free from all the drugs. They are on the zero drug. And immediately after the balloon compression. Could you hear me?
It's a little bit missing. Noise is missing.
I said that the most of the patient of balloon compression are free from all the drugs, be it carbamazepine, gabapentin, or baclofen. But
Yes.
Patients of radio frequency are requiring lesser amount of drug, but most of them are requiring drugs afterward.
In continuation to that, if I am allowed to ask or comment that we may require to repeat radio frequency in after certain times. But
Yes.
what about the balloon decompression? It's once or we can need later on?
Yes, yes, you can repeat it if in cases of recurrence. We have done that also. Unfortunately, very few of our patients till now have come back with the recurrence of balloon compression, and we have done it again. So it was again effective, but in comparison to radio frequency, the recurrence is quite late in the balloon compression. In radio frequency, what our experience has been so far, that most of the patients are coming back within 1.5 years to 2 years time.
Okay, it's
Because
very sufficient time.
yes, that is sufficient time, but in our conditions, we don't consider it good. We want our patient to remain pain-free completely forever, but
Yes,
unfortunately that doesn't
obviously.
happen.
Thank you, thank you. I got that. Thank you.
Yeah, yeah. Thank you.
Hi, everyone. Please leave your questions in the chat box. I will read it to Dr. Anurag. Yeah. So next question from Dr. Ahmed Faham. Sorry if I pronounce it wrong. Is like how to point the trajectory if at X-ray the alveolar covered by the mandibular bone.
Just no, yes, how to
Yeah,
point the
from the
trajectory
chat,
of X-ray
yeah.
the forward. No, yeah, it is a good question actually. Thank you, Dr. Achmat Fahmi. Here it is important to make a perfect submental vertex view, which I showed you in the slide in the video. That first you need to make a caudal inclination, then the ipsilateral oblique inclination till you see the foramen ovale clearly between the mandible on the left side and maxilla on the right side. And then you use the gun barrel or coaxial way of insertion of your cannula towards the foramen ovale. So there is no question. Then your foramen ovale is covered by the mandibular bone. If it is covered by the mandibular bone in the submental view, it means either your C-arm is not oblique enough so that it is under the mandibular bone. So you slightly make it more oblique on the side of the foramen ovale you want to enter, and you will get it clear. I hope I have made myself clear.
Thank you, Doctor. And the next question is from Dr.
Mustaqim, yes, Dr.
Mustafi, yeah, sorry. What is the benefit of said bend-on dilator, and when will you use that kind of dilator? And how to make a pear shape of balloon, like a perfect ideal shape?
Actually, Dr. Mustaqim, this is slightly tricky. Why it is I'm saying that this is tricky? Because we all have found multiple shapes of balloon. But gradually we have learned the pear shape is considered to be the best because it provides best kind of pain relief. So the first part of your question, how to make it a pear shape. So it has been shown in studies and our experience also. While in the submental view, when you first insert your dilator, your cannula, then dilator, if your dilator is slightly towards the medial side of the face of the patient, the chances of placement of your balloon tip is more into the porous trigeminus. As I said, that pear shape is due to the balloon protrusion into the porous trigeminus. So if I can use a example of a room, like a room I'm sitting in, I'm coming from downside, and on the side of the roof, one side there is a porous trigeminus. So our aim is to try to put the tip of balloon into this hole in the roof, that is porous trigeminus, and then only you can get a pear-shaped balloon. Second trick which we try, that if you are not getting the pear shape and you are getting a bullet shape or a dumbbell shape, sorry, not dumbbell shape, you are not getting a rounded balloon, then you may try to deflate the balloon and just make it slightly more forward across the clivus line, maybe 1 or 2 millimeter. And then you can try it to make it more useful. As far as this side bending dilator, personally, I haven't used it till now. I haven't been. It has never been required during my interventions, and it is quite thin also. So maybe the company people can tell us why they have made it. Because the dilator, the main steam dilator, which is 14 gauge, it is good enough if in most of the patients till now.
Thank
Hello.
you, Doctor.
Yeah.
Yeah. Hi. Anybody else who would want to ask questions now? You can raise your hand, the little button down there. Anybody else? Yeah, we got one more questions from Dr. Ahmed again. He just asked the doctor, can you tell us how long the compression time you normally recommend for the new doctors? Yeah. And how, yeah, we have another question.
Dr. Achmat, the compression time which we use in our patient is 90 seconds. Initially, a few years back, I was using 60 seconds, but currently we are using 90 seconds. But there are studies available where people have used compression time of up to 20 minutes. What have our experience been that if we use a longer compression time, there is much more dense hypoesthesia later. We do not have good studies, prospective studies, to compare the time duration and the longevity of pain relief. So it is a compromise between the long-term pain relief and more profound hypoesthesia in the face. So with the 90 seconds, we have found that patient is pain-free with mild hypoesthesia in the face, which is most commonly not bothersome to them. But we are still trying to reach a time which is perhaps the best, maybe in the future. So currently we are using 90 seconds. Dr. Mustaqim has asked, how is the long-term control of PBC?
Yeah. Yeah.
Dr. Mustaqim, I could not get what you are actually wanting to know. But as I said, the long-term results has been good till now. Though we are trying to get our comparative data of last 10 years so that to actually see the recurrence rate and the duration of pain relief in our patient. But of last 5 years, I can say you the recurrence of last 5 years is not more than 10 to 15% till now in my friends. And most of the time, it is after 1 or 2 years, no, at least 2 years in the cases where we have got recovery. Except one patient who had no relief after the balloon compression, only one patient. We repeated it after 1 week, and since then patient is good. It was more than almost 2 years back.
Okay, thank you, doctor, for answering these questions. Any other doctors have any other questions? Yeah, we have one more question coming.
Yes, yes. In based on your experience, what will you recommend? Actually, ours is a teaching program also. We need to do both the things because we need to teach our fellows the radio frequency first and then balloon compression. But my favorite is balloon compression, no doubt, since last 10 years, I can say. I do radio frequency in some patients, but it is mainly for the teaching purposes, or if the patient is absolutely having single division pain of V3, suppose, then only we do the radio frequency. Otherwise, we do balloon compression in most of our patients.
Thank you, doctor. Any other doctors have some questions for Dr. Anurag? Please raise your hands.
Thank you, Dr.
Thank you too, doctor. Yes. Oh, we have one more doctor just joined now. Yeah. Do we have any more questions for Dr. Anurag regarding the PPC procedure or other complications related to questions? We'll wait for another 5 to 6 minutes, and if you still have some questions, this is the last chance.
No. You can, if you are getting questions afterward also, you can forward them to me. I will try to answer.
We have one more question.
Have you ever got diplopia? How do you manage? No. I know few cases where patients have got diplopia, but personally, I haven't experienced this complication till now. So, the patient who had it after a balloon, he was better, I believe, in a month or two. There was an ophthalmology consultation was done, but they said nothing to be doing, nothing doing, need not doing anything actively. And patient was better, perhaps in 6 weeks. But again, that is, I believe, if you are not sure where you are inflating your balloon and there is injury to third nerve, then it may happen. But fortunately, till now, we have been lucky. But this is a good question. It happens. But I know one case which was done by my colleague who had this diplopia complication after the glycerol also. So again, I believe it is related to the placement of your balloon or your glycerol or whatever.
And Dr. Anurag, can I ask a question from my side? Like, can you share?
Why not?
Yeah, share about the clinical study you are doing with the PPC procedure now. Yeah, just enlighten us, please. Yeah.
Actually, what we are trying to, like, as I said, that we were unable to measure the pressure till now, till we had this manometer with us. And personally speaking, I was very much surprised when I first measured the pressure, which was around 2000 millimeter of mercury. With only, we use the total volume of 1 ml, and the actual balloon is inflated by only 0.4 to 0.5 ml, because rest of the dye stays in the lumen of the balloon catheter. So that much of pressure. So what we are trying to do, we are trying to establish any link between the pressure generation, the shape of balloon which we are finally getting, and the duration of pain relief, if we can find any correlation between them, because that may give us more insight to the mechanism, to the efficacy of procedure which we offer. But and another part with this new kit is that in most of the patients, we are getting a good pear shape without much of the problem, which was not so early. So I don't personally know the reasons for that. Perhaps it could be related with the resilience of balloon or the tip of balloon which is reaching at the intended place and which is very much visible on the X-ray, which was not so earlier. So this is what we are trying to do in the Indian patient population which we are.
Okay, thank you, Doctor, for answering my questions. Anybody else have more questions for Dr. Anurag? This would be the best time to ask. Yeah, we got one more questions from Dr.
Yes, Dr. Mustaqim, it happens. It happens. Some patients have dysesthesia and masticatory muscle weakness. But as I said, it is dependent on the duration of compression also. As I said, we are using only 90 seconds. So though around 30% patient complain of mild dysesthesia and masticatory muscle weakness, but there are two things. When we examine them manually, we are unable to find out any weakness when we compare bilaterally. But still patient is complaining that it is difficult for them to chew from that side. But it gets better within 1 month to 2 months. For the dysesthesia part, we use some neuromodulatory drugs. Usually, my favorite is amitriptyline in very low dose of like 10 milligram in the evening, or sometime gabapentin, and it actually helps. One more thing I have seen that when the patient complain that they don't chew from the affected side, many of them are really only afraid of doing that because they are afraid that if they try to chew from that side, their pain might come back. So that fear doesn't allow them to chew from that side. So some reassurance, some amitriptyline, and some gabapentin. And here in my place, a tube of ointment, gabapentin ointment is also available. So I like to use that also to be used in the dysesthetic part where the patient comes. It also helps. But I don't know any physical therapy because I have taken help of my dental friends also, but they were also not able to suggest anything specific for their this dysesthesia or masseteric weakness. But it gets better with the time.
Thank you, Doctor, for excellent answer. Yeah. So now we can conclude. Thank you all, especially Dr. Anurag, and for your valuable time tonight to enlighten all of us about the PBC procedure. And thank you every doctors and take your precious time on Saturday and to attend our webinar. So we expected to connect with all of you in the future. And if you have any more questions regarding our SYM PBC kits, we will ask our salespersons to contact you after this webinar. And thank you all for coming tonight. Thank you. Have a good time. Good night, and everybody. Thank you,
Thank
Dr.
you.
Anurag. Thank you.
Thank you. Best wishes to all of you. Bye.
Yeah, best wishes.